For the next session, the topic is Managing Movement Disorder and Rehabilitation Care. I would like to invite on stage our chairperson, Dr. Mrinal Kanti Roy, former professor of neurology in CNMCH, and Dr. Shankar Prasad Sinha, former professor in PMR department. For the speaker, I would like to invite Dr. Samar Biswas, professor of neurology in NRS.
So, Professor Biswas, he is now in NRS Medical College and Hospital, Kolkata, and he is a specialist. Especially, there are a lot of subspecialties on a particular specialty. Nowadays, in neurology, we have got epileptologist, movement disorder specialist, and he's running a very good clinic over there. So, we'll be hearing Professor Biswas without much ado to the subject. I request him to proceed. What you can learn from him so far as the movement disorder and their management is concerned in the viewpoint of physical medicine.
Thank you, sir. Good morning, everybody. Thanks to the organizer for their invitations. And I have been asked to talk on movement disorders and their managements in a 15 minutes time. Movement disorders encompass the abnormal movement or paucity of movement, that is less movement. It is due to involuntary motor activity. At the same time, it is not attributable to muscle weakness, spasticity, any direct musculoskeletal disorder like osteoarthritis, knees, or systemic slowings like hypothyroidism, because all this can cause slowing of the patient and leading to misdiagnosis of Parkinsonisms. 3 to 8% of all neurological disorders are movement disorders, and 30 to 45 per 1 lakh populations over 60 years have movement disorders. So a huge number of patients are there. Usually they are chronic or subacute onset, but sometimes acutely they can present like in viral encephalitis. Following viral encephalitis, Japanese B is a notorious one, and following there may be strokes which can lead to movement disorders. And in movement disorders clinic, around 10% patients are due to drug induced. We already known that movement disorders are due to structures involved or functions involved in the basal ganglia regions. This is putamen, this is globus pallidus, this is caudate, this is thalamus, substantia nigra in the midbrain. These are, and their connection with the cortex and inferior structures are the basis of neuroanatomy of movement disorders. And this is T2 MRI, which also shows the structures of the brain. Now, neurotransmitters are the cornerstone in pathogenesis of movement disorders. Dopamine being the facilitates movements, basal ganglia circuit. When it decreases, it produces Parkinsonism. When it increases, it produces Huntington disease, chorea, tardive dyskinesia. Acetylcholine is opposite to dopamine. Its increase produces Parkinsonism and dystonia. GABA is inhibitory neurotransmitter. When it decreases, it increases the movement, like in Huntington's chorea, myoclonus. Glutamate is opposite to GABA. It is main excitatory neurotransmitters. Serotonin, norepinephrine, they have some role, particularly in Parkinsonism, particularly in non-motor symptoms. Movement disorders are basically classified into two major groups. One is hypokinesia. The Parkinsonism is the prototype of that, and hyperkinetic movements. So many, there are hundreds of hyperkinetic movements, starting from dystonia, chorea, bellism, tics, and all, and so on. Parkinsonisms are basically three types. Idiopathic Parkinsonisms, which is otherwise known as typical Parkinsonisms or Parkinson's disease. As there is typical, so there is atypical Parkinsonisms. And secondary, meaning secondary to underlying structural damage of the brain. These are the four bradykinesia, rigidity, resting tremor, and postural instability. These are the 4 main features or core features of Parkinsonism. If one, bradykinesia, rigidity, either of the one is present, only either bradykinesia or rigidity qualify for Parkinsonism. But to qualify Parkinson's disease or idiopathic Parkinson's disease, you need at least 3 of the 4 features. Amongst them, one must be either bradykinesia or rigidity. So, like for all chronic progressive disease, it has got some stage of evolutions. And you see, before the motor features develop, a decade, maybe a decade earlier, you can get some non-motor features in the form of hyposmia, anosmia, sleep disorders, or and as the disease progresses, the motor features appears. In early stage, you get bradykinesia, rigidity, tremor, and as it advances more, postural instability and more of midline symptoms like dysphagia develops. Like non-motor symptoms are also additive as the disease progresses. Cognitive impairment and other behavioral problems may appear later in the stage of the disease. Now, typical PD or IPD actually gradually onset, asymmetric onset. Tremor is the main part of the disease. Levodopa response is the rule. Falls, autonomic dysfunction, cognitive decline, they are not so early. They may appear but late. Whereas in atypical Parkinsonism, it may be symmetric. Tremor is less. Response to levodopa either poor or no, but falls, autonomic dysfunction, cognitive decline, and they are very early. And depending on the symptom present in the atypical Parkinsonism, there are 4 major types of atypical Parkinsonism like PSP, MSA, CBGD, and DLB. Secondary Parkinson may develop from repeated trauma in case of boxers or other sports. Hydrocephalus, NPH, is a common cause of secondary Parkinsonism, and infection, vascular, metabolic disorders. They present often symmetric onset. They are poor responsive to levodopa, and usually they present in the lower half of the body. These are the red flags for early and prominent dementia, symmetric signs, bulbar dysfunction, early gait, falls within 1 year, and so on. These are when a patient presenting with these in the early symptoms, we reluctant, we are hesitant to diagnose IPD, rather they are atypical Parkinsonisms. So what is the principles of treatment? After diagnosis, if the minimal motor features are minimal or none, we can treat with exercise and MAO inhibitors. Exercise has got some immense role in Parkinsonism disease. We will learn from the next speaker. And as the disease progresses, we start dopamine agonist and then levodopa. And in more advanced cases, we can go for entacapone, pramipexole, ropinirole, and other drugs. And if it is more advanced, we can have the provision of intervention like DBS and others. When the diagnosis is uncertain, so in that case we can take some help of imagings in the form of MRI, which show structural imaging, and maybe functional imaging like DATs or VMAT imagings. On treating the patients, we must remember 2 important things. One, that levodopa is the cornerstone of the drugs, and it produces the most consistent, sustained, and predictable response. At the same time, levodopa invariably produces complications like dyskinesia in due course of times. So, the basic principles is levodopa. We start levodopa as late as possible to avoid dyskinesias. But in our country, like poor socioeconomic status, when a patient who is the only earning member of the family, then we can introduce levodopa early to make the patients functional for the family. Now for hyperkinetic movements, chorea, irregular dance-like movements. Dystonia is sustained posturing of the one limb or generalized posturings. Tremor is a rhythmic movement, repetitive rhythmic movement, to and fro movement. Balism is a violent flinging proximal involvement of the movement. Myoclonus, sudden brief shock-like jerks, and tics are repetitive stereotype motor or vocal tics. It may be suppressible sometimes. In a disease process, we usually get combinations of the hyperkinetic or movement disorders. Like in Parkinson's disease, we may get tremor and akinesia. In Huntington disease, we can get chorea, dystonia, bradykinesia. In Wilson's disease, we may get tremor, dystonia, akinetic disease, and so on. The treatment of dystonia, it depends on the morphology. It is whether it is focal or it is generalized. In all cases, we start drugs. Suppose it's generalized dystonia, we start anticholinergic drugs, tetrabenazine, muscle relaxant in the form of baclofen. But in generalized dystonia, they are very resistant to treatment. We may go for intrathecal baclofen, which we'll learn in the next session. And ultimately, we may go for DBS. And focal dystonia, focal or segmental, we initially start with drugs, all these drugs, but they are very much good responsive to botulinum toxins. In fact, their first line treatment is botulinum toxins in some of the hyperkinetic, some of the dystonias. In dystonia in a child, particularly female, always starts with levodopa. It can be DRD, dopa responsive dystonia. They are very much responsive to low doses of levodopa. In hemifacial spasm, you see botulinum toxin is the first line treatment. Tremor, propanol, primidone, these are the drugs. Tics, risperidone, botulinum toxins. Chorea, tetrabenazine is the drug of choice. Tardive dyskinesia, you have to withdraw the drug first, give tetrabenazines. Restless leg symptom, many things are applied: dopamine agonist, levodopa, iron, gabapentin. Myoclonus, you give clonazepam, levetiracetam, piracetam, valproate. Now, botulinum toxin in movement disorders. It actually blocks the acetylcholine release at the neuromuscular junctions. So practically it produces muscle weakness. It has got local effects, no side effects. It is reversible. If there is adverse effects of weakness, it is improved by weeks or months. Some of the diseases, it is first line treatment like focal dystonia and hemifacial, already said, but in some other diseases, it can be useful also. Hemifacial spasm is a common movement disorder. It involves the one side of the face, muscles of the one side of facial muscles undergoes spasm. It may start on the upper limb, then it can involve the lower, or simultaneously. And sometimes it may be caused by irritation of the seventh cranial nerve in the midbrain by an artery compressing the nerve. So in those cases, we are giving botulinum toxins. Because they are small muscles, we are starting with 2 to 3 units.
2 minutes more, please.
All the small muscles are being targeted. All the small muscles supplied by the facial nerves are targeted: frontalis, orbicularis, oculi, and upper part, lower part, 2 units each. And other muscles of the face, zygomaticus, mentalis, we use very small amounts of botulinum toxins, 30 units in 10 to 12 divided sites, and see the response. That patient came follow up after 1 month. There is lower half, there is no movement, and upper half also movement is decreased. Blepharospasm is also a very common focal onset dystonia characterized by involuntary contractions of the periocular muscles on both sides, impairing and daily life. Even functionally blind, patient may become functionally blind. We use botulinum toxins on both sides, five sides here, 5 sides over, periocular muscles and frontalis. Also, we start 30 to 35 units to all, 3 units per side on 10 sides. And you see the response after 1 month, there is complete obliterations of the movement. Cervical dystonia, this is named. Also,
sum up.
Yes. Few points on DBS in the Parkinson's disease. Moderately severe patients with poor quality of life, fluctuating response, troublesome dyskinesia, and levodopa unresponsive. DBS is an implanted pulse generator. Placement of leads 4 to 8 sites, specifically in the predetermined sites of the brain. We can go for thalamic, GPI, STN. GPI DBS is preferred, and it has been some reports or shown that even RCT shows that there is marked improvement compared to the best medical therapy. But not all movements are amenable to treatment. Tremors and postural instability are poorly responding to DBS. And success depends on the appropriate selection and skill of the surgeon, of course. This is the DBS. The pulse generator is implanted over the chest. It is connected with the leads, and 4 to 8 areas lead are placed. High frequency stimulation helps to resynchronize the electrical activity of subthalamic nucleus, which lead to increased dopamine release in the substantia nigra, and ultimately movements are improved. Is also found helpful in other conditions. So, to take basic take-up message is the beauty of the movement disorders are it is primarily diagnosed clinically. Investigations are less important. All patients of Parkinson's disease should receive a levodopa trial. Hyperkinetic movements, particularly when it's generalized, very difficult to treat. Focal and segmental dystonias very respond to botulinum toxins, and selected cases of Parkinsonism, advanced Parkinsonism, may benefit from DBS. And thank you.
So, a very good exposition of a very big subject. Time is very short, we cannot cover everything. Thank you, Professor.
Thank you.
And one comment I like just to make for 30 seconds. In movement disorder, I tell my students actually that they always try to make a phenomenology. Phenomenology means whether we are dealing with a hypokinetic or a hyperkinetic. The prototype of hypokinetic is clearly mentioned Parkinson, and hyperkinetic lots of starting from chorea, dystonia, Bellism, all these things, myoclonus. Now in case of Parkinson, in a clinical practice, what you do? Sometimes the people with osteoarthritis, bilateral osteoarthritis, if you look at these patients, they are coming, you have to think about 2 or 3 things. Number one, what is the cadence of these patients? What is the stride? How much amount of lifting of the feet from the ground? How much they are clearing the ground? But there is a very classical, along with the hands, there is a short shuffling or not. So sometimes you can miss out that the patient is concomitant having a bilateral osteoarthritis along with the Parkinson's disease. This is one point I have seen, and I always tell my students, try to exclude, see the knee at least. Number 2, very important point is that in treating all these things, probably you have mentioned the DBS, but it is not so easily affordable. It's almost 25 lakhs. 25 lakhs.
In selected patients, and if the patient has got economy is not a concern, then
yeah, definitely. But you have to think. Thank you. Thank you very much.